professional, so we can be on our feet.
Nigeria, we hail thee, our own.
is my pleasure to welcome you to the 5th inaugural lecture of our university. This inaugural lecture will be given by a professor of orthopedic rehabilitation and pharmacophysiotherapy, Professor Ayodele Teslim Onigbinde. Professor Onigbinde started his career on his career pathway when he attended the Obafemi Awolowo University, from where he graduated in 1990. He has then since moved on to complete his master's and his PhD degree program in the area of sports science in the University of Ilorin. He started his teaching career in Obafemi Awolowo University, where he was an alumnus, and today he is not just a member of our university community, he is also proudly the first substantive dean of Nigeria's first faculty of medical rehabilitation. It is my pleasure, ladies and gentlemen, to invite Professor Onigbinde as he delivers his inaugural lecture today, titled Myriad of Pain and Disability, the Therapeutic Effect of the Fingers and the Needle-Free Injection. Professor Onigbinde.
The Vice Chancellor, sir, the Deputy Vice Chancellor of Academics, the Registrar, the Bursar, and the Librarian, Deans of Faculties, all distinguished professors and members of the University Senate, directors and heads of departments and units, family members and friends, my professional colleagues, students, gentlemen of the press, distinguished ladies and gentlemen. The preamble. The journey of a man begins from the day of conception in the mother's womb. According to Book 55 of Sahih Bukhari, Volume 4, number 549, as narrated by Abdullah. Every one of you is collected in the womb of his mother for the first 40 days. Then it becomes a cloth for another 40 days, and then a piece of flesh for another 40 days. Then Allah sends an agent to write 4 words. He writes his deeds, time of his death, means of his livelihood, and whether he be wretched or blessed. What I am today has been preserved by the Almighty Allah. Mr. Vice Chancellor, sir, I am delighted to stand before this distinguished audience to present the 5th inaugural lecture of Nigeria's first specialized health and medical sciences university, the University of Medical Sciences, Ondo City, and the first inaugural lecture to be delivered from the Faculty of Medical Rehabilitation. Incidentally, the first of such faculty in Nigeria and West Africa. The pathway to glory has, however, not been pain-free. Pain has been there even before birth and at delivery. But must we experience pain? Yes, even the repair process after a damage or injury gives pain. Naturally, with aging, the human body experiences wear and tear. A misused, injured, untreated, and mechanically deranged human body will produce pain, leading subsequently to disability, reduction, and loss of physical function. Pain and loss of physical function impair activities of daily living with negative economic implication and low quality of life. These are the challenges a therapist faces on a daily basis in his or her career to fix a physically deranged human body. In my 34 years of practicing as physiotherapist, I have managed a huge number of patients or clients struggling with pain from diverse causes, and I have dedicated a significant proportion of my academic life undertaking research to contribute to improve the management of pain. These experiences influence the choice of my topics for this lecture: myriad of pain and disability, the therapeutic effects of the fingers, and the needle-free injection. The roadmap for this lecture is as follows. 1, the earlier career journey and my transition to academics. Academic life and research endeavors. And thirdly, teaching-related engagement, academic leadership, and distinctions. The earlier career journey and transition to academics. Early journey before academics. Mr. Vice Chancellor, sir, not many professors will have spent almost 15 years in the clinic before crossing to academics. that was exactly what I did. After my secondary education in 1983, I knew what I did not wish to study. I wanted to treat the sick, but not interested in being a doctor, a nurse, or a pharmacist. My uncle, Mr. Gbebi Abimbola, a United Kingdom-based nurse, might not realize what he did to kickstart my career. My father sent for him to counsel me on a medical career, as he considered me a confused young man. Uncle Abimbola looked at me thoughtfully and he said, "Will you study physiotherapy?" I had no idea what physiotherapy was. He took me to General Hospital Osogbo to meet Mr. Folorun Ishola, a physiotherapist who was based in Ibadan, but was coming to Osogbo, Ikirun, and in large towns to treat booked patients every Wednesday. The journey into physiotherapy began that fateful Wednesday when Mr. Ishola showed me around the physiotherapy department of General Hospital Osogbo, now Osun State University Teaching Hospital. He showed me an ice-making machine in the first cubicle. He opened it and he scooped out ice flakes. I had never seen ice blocks in flakes form before. He tried to explain the usage to me, but all he said did not make any sense or did not make much sense. He moved to the second cubicle. In the cubicle was a machine that was moving the foot of an 8-year-old boy with resting interval between the interaction. I asked Mr. Ishola 2 questions. First, what was wrong with the child? I asked, is it the machine that was moving the foot of the boy? To the first question, Mr. Ishola explained that the boy had malaria and was given an intramuscular injection, and the needle impinged on the nerve at the buttock. Thus, the muscles supplied by the affected nerve were affected, and the boy could not control the foot again. To the second question, he said yes, and that the machine is called electrical muscle stimulator. And it will activate the affected muscle back to action. The machine in this cubicle inspired me to study physiotherapy. And I said, Eureka! I told my uncle there was no need to go to any other cubicle, as I have found a course to study. From that day, I started to wonder if injection with a needle could be avoided if there is an alternative. I chose the then University of Ife, now Obafemi Awolowo University Ile-Ife, to study medical rehabilitation with focus on physiotherapy, and I graduated in 1990. After graduation, I was posted to Bauchi State Sports Medical Center, Bauchi State Pork Commission, popularly known as the Mecca of Sport for the National Youth Service Corps Scheme. Incidentally, Bauchi State was to host the National Youth Sports Festival in 1991. Thus, I entered into the realm of sport medicine. In my sojourn in sport medicine, I served on several medical committees for different sporting competitions between 1990 and 1996. The climax was my membership of the medical team for the Olympic Games, Spain, Bauchi Camp in 1992, All African Games, Bauchi Camp 1995, and 8 All African Games, Harare, Zimbabwe in 1995. The use of medication in sport medicine is so diverse for all experts in the field. This challenge spurred me into exploring area of medication in physiotherapy later in my academic career. I left sport medicine practice in 1996 for a clinical job at the General Hospital Osogbo, where I had to work under the man who stimulated my interest into physiotherapy, Mr. Folorun Ishola. I worked under him for a few months, but I found the job very unchallenging, and the remuneration was quite poor. Thus, I needed to search for a better offer. In 1997, I took one appointment at the University of London Hospital in Ilorin as a clinical physiotherapy, where the calling into the academics came. Back then, my colleagues were always telling me that I did not belong to the clinic, but the academics. With the encouragement of Mr. Alfred Abegunde, the then head of department, I enrolled for my master's degree in exercise physiology at University of Ilorin and graduated in 2001. I moved into academics in the second half of 2004, and I obtained my PhD later. The transition to academics, my motivation. Education holds a paramount position in life. The hadith of the Holy Prophet sallallahu alaihi wasallam says, God is angels and all those in the heavens and the earth, including hearts in their hills and fish in their water, send down blessing on those who educate others in beneficial knowledge. There is no doubt Allah gives blessing to whoever imparts knowledge on others. There are numerous specialties in the field of physiotherapy, but the success achieved in the rehabilitation of patients with musculoskeletal disorder during my 14 years in the clinic, most especially as a sport physiotherapist, made me to focus on orthopedics, academics life and research endeavors, potential for expanding the scope of physiotherapy practice. There has been paradigm shift and unrelenting transformation of boundaries in the statutory roles of allied health professions, creating new roles and expanding the existing traditional role. This is a strategic approach towards improving healthcare services. Supplementary prescribing has been defined as a voluntary partnership between an independent prescriber, a physician or dentist, and a supplementary prescriber to implement and agree patient-specific clinical management plans with the patient's agreement. This is according to Chartered Society of Physiotherapy in 2013. The supplementary, who is also known as dependent prescribers, have responsibilities which include continuing the plans developed for the patient by independent prescribers. The use of medication has become an indispensable adjunct to the effectiveness of the practice of physiotherapy. In the United Kingdom, some specially trained physiotherapists had even upgraded from being supplementary to independent prescriber as far as 2012. This is also according to Chartered Society of Physiotherapy in 2013. Over the years, I have initiated several studies focusing on establishing the need for expansion of the scope of physiotherapy in Nigeria. In one of the studies, most physiotherapists, 83.8%, expressed the wish to be supplementary prescriber of oral and injectable drugs. 73.8% would like to prescribe analgesic. 73.8% also wish to prescribe non-steroidal inflammatory drug, and 59.2% would like to prescribe muscle relaxant, according to a study by Onigbinde et al. In 2013. The interest in prescribing analgesic, NSAIDs, and muscle relaxant might be due to the pain usually experienced by clients and difficulties associated with the management of spasticity, which contributes to severe impairment of motor functions. In Nigeria, it appears physiotherapists have very little formal training in drug therapies, and the ability to give appropriate advice to patients on medication is in doubt. Pharmacology education was introduced to physiotherapy curriculum a few decades back, implying that we have two categories of clinicians. In a study, we found that 71.9% and 78.0% of Nigerian physiotherapists were with and without pharmacology education, respectively. However, 81.3% and 80% of those with and without pharmacology education, respectively, agreed that an extensive knowledge of pharmacotherapy will be useful in clinical practice and that it will increase quality of clinical practice. A significant proportion of the therapists agreed on the relevance of pharmacology knowledge. The study actually concluded that both physiotherapists with and without pharmacology training have poor knowledge of medication. In another study, only 40.7% recently updated their knowledge on topical medications. However, this contradicted the findings that only one participant, that is 0.7%, had very good knowledge, while 42.2% had poor knowledge of the active ingredients in the topical medications listed in the study. And this is an evidence that they cannot practice the procedure of iontophoresis. Generally, the study revealed that physiotherapists have poor knowledge about adverse reaction, contraindications, risks and mechanism of action of the listed drugs, and how non-steroidal inflammatory drugs relieve pain. Whereas most NSAIDs inhibit inflammatory mediators by inhibiting cyclooxygenase enzymes, which reduces the production of precursors such as thromboxane and prostaglandin, and this subsequently terminates the inflammatory pathways. In my years of clinical experience, only very few patients appear to be aware of phonophoresis and iontophoresis as alternative means of administering drugs where applicable. Phonophoresis refers to the use of therapeutic antidepressant to increase the percutaneous absorption of a drug, most times to treat pain and inflammation, while iontophoresis involves the introduction of ionic medicinal compounds across the brain using galvanic electric current. The role of alternative methods of administering drugs needed to be made available to patients where applicable, as they can exercise their rights to healthcare choices. This is a call for more advocacy on alternative means of administering drugs aside from the use of oral administration and injections. Selected musculoskeletal pain and disability issues in the Nigerian environment. Physiotherapies all over the world will continue to be relevant in pain management, as it is a chief precursor to deformity and disability. The International Association of the Study of Pain in July 2020 revised the definition of pain as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. Pain is and will continue to be a challenge to all health professionals and numerous clients. Pain can be acute, subacute, or chronic. A disability is any condition of the body or mind which is referred to as impairment that makes it more difficult for the person with the condition to do certain activities, which is known as activity limitation, and interact with the world around them, which is referred to as participation restriction, according to CDC in 2024. Both pain and disability pose significant challenges to the use of medications alone. The myriads of pain require multimodal intervention and multidisciplinary approaches. Pain has become a phenomenon that requires attention much more than just clinical management alone. Persistent chronic pain that is unresponsive to only pharmacology therapy will substantially impede a normal lifestyle. Hence, it must be treated using multimodal approaches. Most Nigerian workers are facing the challenge of the on-job injuries, but there are a few empirical data on occupational hazard faced by several groups. Physiotherapists, by the nature of their professional engagement, may be prone to occupational injuries, but research data had hitherto been scarce. In a study, we observed that 70% of physiotherapists had past history of occupational injuries. The most prevalent injured body parts were lower back, which accounted for 45.2%, the wrist and hand, 26%, the mid-back, 10.6%, and the neck, 6.7%. This is according to BMB et al. In 2008. The highest job risk factors were during application of manual therapy, which accounted for 20.9%, transferring patients, 13.8%, and maintaining static position for a long time, 12.2%. Muscle strain was the commonest type of injury, which accounted for 55%. The significance of this is that physiotherapists must adopt appropriate lifting techniques and strategies when offering treatment to patients to avoid developing musculoskeletal injuries. Occupational injuries are increasing, and this is increasing job risk. One of our recent studies showed high prevalence of hamstring tightness among professional drivers, non-professional drivers, and non-drivers to be 78%, 54%, and 60% respectively, according to the findings of Ayodele et al. 2024. The clinical implication of this study is that there is a likelihood that hamstring tightness among drivers will predispose them to poor flexibility, low speed, and poor power and agility at the affected lower extremity during driving. Prolonged sitting posture during driving has been reported to account for half of work-related musculoskeletal dysfunction, and this is according to the findings of Dong et al. 2022 and Bale et al. In 2023. Managing musculoskeletal pain and disability by using needle-free injection. The application of electrical stimulation for the purpose of alleviating pain is known as electroanalgesia. And most topical analgesic and non-steroidal anti-inflammatory drugs can be administered using the procedure of iontophoresis. Iontophoresis is referred to as injection without the needle. It provides a 20 to 60-fold increase in penetration over applying topical medication through massage. This is according to the findings of Gangarosa in 1995. Electromotive drug administration is the alternate physical therapy procedure of administering drugs through the skin. The stratum corneum affects the permeability of topical drugs, while the appendage is known as the shortcut for topical drug delivery. For drug transmission through the skin, there are three pathways, namely intercellular, intracellular, and the appendageal, which is also referred to as the short pathway, and these are according to Polimi in 2023. The appendageal pathway utilizes the hair follicles, sweat ducts, and secretory glands. The common means of electromotive drug administration through the skin in therapy are iontophoresis and phonophoresis. However, I am positively biased towards the use of iontophoresis. Iontophoresis is a non-invasive method of propelling high concentration of a charged substance, medication, or bioactive agents transdermally by a repulsive electromotive force using a small electric charge. It has become increasingly important to improve the knowledge of therapists about iontophoresis since it involves topical medication. In one of my research work, only 53.7% of Nigerian therapists chose correctly galvanic, the interrupted galvanic current, as the mode required to use for the application of iontophoresis, while more than a third, 35%, were wrong in their approach. These are according to the findings of Onigbinde and Orolade in 2012. More than a tenth of the therapists, 12.2%, had no idea of appropriate placement of electrode. This finding established that few physiotherapists in Nigeria have adequate knowledge about iontophoresis and are not using it as a treatment option. Iontophoresis, disease-modifying drugs, methyl salicylate, and exercise therapy. Low back pain is a major problem worldwide, and lumbar spondylosis remains a major cause of disability. There are numerous clients who are prevented from normal functioning because of pain and disability arising from low back pain. Currently, there is no cure for osteoarthritis, and it is usually managed by a combination of treatments. Attention is now being shifted to the use of topical formulation of disease-modifying drugs such as glucosamine and chondroitin in order to stop the progression of arthritis. There are speculations that if the crystalline form of glucosamine sulfate is combined with low metal salt, either sodium or potassium, it might be more effective to significantly reduce pain experienced by clients. In a clinical trial that I initiated, we investigated the use of a 300-gram gel containing 8% glucosamine sulfate with low potassium, methyl salicylate cream, and glucosamine cream. The drugs were administered through iontophoresis to the low back of the client experiencing pain. We found that the compounded glucosamine with low potassium significantly reduced the pain experience after 4 weeks of treatment compared to the other two groups that had glucosamine iontophoresis and methyl salicylate ointment. My advocacy is that this should be adopted in clinical practice. Exercise and electroanaesthesia are commonly used in physiotherapy practice to manage peripheral joint arthritis. However, exercise is probably the least thing most patients with osteoarthritis will embark on when experiencing pain, especially at the acute stage. Till date, controversy still trails which treatment technique is more superior over the other in the management of pain and improving physical function. This is according to Lasisi et al. 2024. I led a team of researchers to compare the efficacy of psychoergometry exercise therapy and glucosamine sulfate iontophoresis in managing pain experience among subjects with subacute osteoarthritis. This is a study that was done in 2011. Interestingly, we found that the combination of exercise therapy with glucosamine sulfate iontophoresis was not superior in relieving pain, better than using exercise therapy only, although both techniques were effective in pain management. The needle-free injection, glucosamine sulfate, and the plasma glucose. While iontophoresis is a non-invasive procedure, a minimal portion gets into the systemic via microcirculation, and this is the reason why the administration of glucosamine sulfate is being speculated to alter glucose metabolism, being a sugar. Contradictory reports have continued to trail the effect of glucosamine on blood glucose level in different studies. Munani et al. 2000, Powell et al. 2000, and Biggie et al. 2006. We found that glucosamine sulfate iontophoresis did not raise plasma concentration of glucose despite being a sugar. Onigbinde et al. 2011b. The outcomes of our study generated commendation from Mohan Vikram and Joseph Leonard, who are researchers in Bournemouth University in the United Kingdom. However, they sought for more information on the applicability of the study with the design adopted and physiological explanation on why there was depletion in plasma glucose despite the application of glucosamine sulfate iodophoresis only. In our response to these queries, we emphasize that our study was a preliminary experimental study in a verdant area of patient care, but we expected it to serve as a foundation for future studies. In my opinion, the study has potential clinical applicability and usefulness in spite of being a quasi-experimental study, with its limitation of inability to completely control for extraneous variables. We attributed the lower plasma glucose level among the participants who had glucosamine sulfate iodophoresis to the effect of the electrical muscle stimulation. There are electrical signal that causes cross bridge between myosin and actin during the application of EMS, leading to first generation. The minimal tetanic contraction during the procedure of iontophoresis compresses the blood vessels within the muscle, resulting in diminished blood flow, which will subsequently reduce the glucose level. The response was published again by Hong Kong Physiotherapy Journal, Onigbinde et al. 2012. The potentiality of glucosamine iontophoresis in controlling glucose concentration in cases of hyperglycemia may require investigation in diabetic patients in the future, and this may properly expand the scope of practice of therapy alongside the previous use of exercise in diabetic clients. Glucosamine and monitoring disease progression using biomarkers. Mr. Vice Chancellor, sir, distinguished audience, the field of physiotherapy is increasingly being evidence-driven, and there are committed efforts to providing clinical justification and scientific reasons for therapeutic effects for its numerous interventions. Increasingly, investigations are being conducted into the physiological, molecular, and anatomic changes in the inner tissues as a result of interventions. The effect of glucosamine in osteoarthritis are multifaceted, especially being a disease-modifying drug. However, the magnitude of the effect and that of chondroitin on pain and chemical changes remain unclear and largely controversial, and this is according to a report of McLeodon in the year 2000 and TGORC in 2005. Both drugs are two molecular building blocks found in articular cartilage, and most clinical research suggested that they have potentiality to retard progression or regenerate damaged cartilage, JOC 2011. Most of the clinical trials regarding this drug in the past adopted either the use of oral or intramuscular injection in the administration of glucosamine and chondroitin sulfate. In one of our studies, we monitored the changes in the concentration of biomarkers, interleukin-6 and uric acid in clients with knee osteoarthritis, with the aim of quantifying the process of joint remodeling and disease progression. Our findings show that the addition of both glucosamine sulfate and chondroitin sulfate significantly reduce inflammatory reactions. However, chondroitin sulfate significantly lowered the interleukin-6 compared to glucosamine sulfate, but had no effect on uric acid concentration. This is according to Onigbinde et al. 2023. Also, there was no significant change in cartilage thickening after 3 months. Chemical enhancers and use of injection without a needle. Following drug administration, a delivery system is required to facilitate absorption because drugs cannot deliver themselves. There are 3 generation formation enhancers, and the procedure of iontophoresis and the use of chemical enhancer belongs to the 2nd generation. The use of chemical enhancer cannot be neglected in clinical therapy because almost all topical medication will benefit from being driven easily through the skin. Physiotherapists are conversant with the use of methylated spirit, 7% alcohol, and soap as surfactant, but it is important to widen knowledge on the use of other relevant chemical enhancers, such as sorbitan monohydrate and polysorbate 20. Sorbitan monohydrate is a non-ionic surfactant, and it is capable of lowering surface tension of a liquid and interfacial tension between 2 liquids, or the tension between a liquid and a solid. A surfactant can be ionic, non-ionic, or neutral. In choosing surfactant, We should prevent ionic competition during iontophoresis, bearing it in mind that the procedure of iontophoresis utilizes the principles of like charges repel and unlike charges attract. Considering the need to make transition of drugs through the skin easier, our team investigated the effect of different concentrations of sorbitol moniolate and methylated spirit in enhancing permission of diclofenac diethyl cream when administered through iontophoresis. The outcome showed that there was no significant difference in the cumulative effect of 1% and 0.5% sorbitol monoholate concentration and methylated spirits after 4 weeks, Onigbinde et al. 2013. However, 1% weight by volume of sorbitol monoholate and methylated spirit enhanced reduction in pain intensity and increased knee flexion immediately after the first treatment session. The clinical implication is that 1% weight by volume of sorbitol monoholate and methylated spirit can provide immediate decrease in pain and an increased knee function when used as permission enhancer for topical diclofenac gel iontophoresis. In another study, polysorbate 20 was found to be a better permission enhancer for sorbitol iontophoresis than ethanol and tap water in the management of symptoms of low back pain, as there was significant reduction in pain intensity and disability index after 6 weeks. This is according to a study by Onigbinde et al. In 2017. Joint modulation techniques are adopted to alleviate pain and improve mobility in patients with musculoskeletal disorder. The two major effects of mobilization techniques are the mechanical, which is the flow of synovial fluid and blood containing nutrients for healing to that area, and the neurophysiological effect, which is referred to as the pain gate theory. Patients usually develop apprehension due to pain when the physiotherapist attempts to mobilize the affected joint. Some researchers have previously established the analgesic effect of lidocaine patch, this Chang-Hun et al. In 2022. We had to determine the effect of lidocaine gel iontophoresis on pain experienced by patients with knee OA and lumbar spondylosis during application of mobilization techniques. We found that the application of lidocaine gel through iontophoresis significantly increased the pain threshold of the patient during the application of distraction and gliding techniques, and it also increased the knee range of motion. This is according to a study, Onigbinde et al. In 2010. Muscle relaxation and injection without the needle. The simplest way to describe spasticity is that it is an exaggerated, involuntary, and velocity-dependent muscle tone that restricts movement after damage to the central nervous system. Spasticity leads to disability. Most mild and moderate spasticity cases can be effectively managed conservatively using available oral therapies. However, there is less responsiveness to drug therapies in cases of severe spasticity, and this necessitates the need for exploration of alternative techniques. Among drugs being considered for therapy is magnesium sulfate, which is a naturally occurring mineral and is often seen in the heptahydrate sulfate mineral, hepsomite. Magnesium sulfate has been known to be a muscle relaxant and vasodilator, and is physiologically considered to be an antagonist of calcium. This prompted my quest to explore the option of administering magnesium sulfate using the process of iontophoresis, and also comparing the effect with that of the conventional cryotherapy and passive stretching on spasticity of the elbow flexors of stroke survivors. We undertook 2 studies to ascertain the effectiveness of magnesium sulfate as a muscle relaxant for post-stroke spasticity, Onigbinde et al. 2013 and Onigbinde et al. 2024. The result of both studies showed significant reduction in spasticity rates post-intervention in both magnesium sulfate iontophoresis using a dose of 40 milliamperes minutes and cryotherapy group, and when cryotherapy alone was applied. When magnesium sulfate iontophoresis alone was applied, and a combination of both methods showed significant reduction in spasticity, and they were effective in alleviating spasticity immediately after the first intervention. Similarly, after 6 weeks, the same trend of spasticity relief was observed for the 3 interventions. However, none was superior over the other after 6 weeks. In future study, however, none was superior over the other after 6 weeks. We are considering the use of longer duration than 6 weeks in future study because spasticity is a chronic hypertonicity, and it may require longer duration of rehabilitation to achieve more effective results. expanding scope of practice in the management of decupitous ulcers. Patients on prolonged hospital admission in hospital are at risk of developing pressure sores. In the quest to provide relevant empirical data on pressure ulcer in Nigeria, we investigated 318 patients on hospital admission and found the incident rate to be 13.84%, Onigbinde et al. 2012. Spinal cord injury was the clinical condition most associated with pressure ulcer development, accounting for 50%, followed by orthopedic cases, 30.6%, and head injury, 11.4%. Interdisciplinary team care improves outcome in many patients with chronic wounds. However, in some clients, the role of therapy as adjunctive care in wound care is either not known or it is being underutilized. Considering the increasing incidence, there may be need to involve all relevant professionals for effective prevention and treatment of decupitous ulcers, especially with the emergence of antibiotic-resistant pathogens that slow down healing process. Nurses have the primary responsibility to address wounds in Nigeria, and we needed to evaluate their knowledge of therapy and the need to promote collaboration and avoid interdisciplinary conflict. Our study, Onigbinde et al. 2023, showed that only about a third of nurses in our study setting, 30.3%, had previously co-managed decupitous ulcer with physiotherapists. Less than 1/10 of the nurses, 9.7 and 9.8%, had knowledge of electrical stimulation and iontophoresis as being relevant in the treatment of decupitous ulcers. Furthermore, only 8% and 42.5% had knowledge on the bactericidal effect of antibiotic antiphoresis and ultraviolet radiation therapy, respectively. However, about 2/3 of the nurses, 65.1%, indicated their willingness to co-manage decupitous ulcer with physiotherapists in a teamwork. With the quest to establish the efficacy of physiotherapy in decupitous ulcer, my team employed ultraviolet radiation for 6 weeks with the UVR modality used as adjunct to the traditional saline wet to moist wound dressing by the nurses. There was significant reduction in the mean surface area of the decupitous ulcer when the experimental limbs were compared with the control limb, with a decrease from 78.9% to 37.4% decrease, and also in the volumetric assessment of the wound site, also decreased from 74.7% to 46.3% decrease, and an increase in epithelial growth, Onigbinde et al. 2010. I find it very difficult to forget the words of Ms. Olafiyan of Oyeke, a laboratory scientist and co-researcher, who usually quantify the bacterial colony in each wound. She said, "Dr. Onigbinde, are you sure the specimen you are bringing are from the same wounds?" I asked her why. She responded, "I could hardly see any colony of bacteria. I was amused, and I said, that was the magic of the UV herb. It is noteworthy that the bacteria colonized wounds were treated were not only responding to the combination of oral antibiotics and injection therapy and traditional wound dressing for several months by the team of surgeons and nurses, antibiotics and injection without the needle. Gentamicin is an antibiotic agent, but its transdermal delivery is considered non-feasible because it has low permeability through the dermis. I speculated that its permeation might be enhanced using procedure of needle without injection. I explored an option of a case report using 15-minute gentamicin sulfate iontophoresis on a patient with bilateral gluteal decupitous ulcer 3 times a week for 5 weeks in a patient with mild end injury. We found that there was a 67.5% decrease in the wound surface area and significant decrease in bacterial growth from very heavy to scanty growth when gentamicin sulfate iontophoresis was used as adjunct with traditional saline wet to moist wound dressing, Onigbinde et al. 2011. Exercise, physical agents and drugs, the meeting point. Through a systematic review of literature, we established that exercise affects pharmacokinetic variables of drugs, resulting in either positive or negative influence depending on the type of drugs, exercises, exercise intensity, duration, and the excretory organ, Onigbinde et al. 2009. Exercise affects bioavailability of drugs, thereby increasing the kinetic molecular movement of drugs, and this subsequently increases diffusion across the biological membrane. Thus, physiotherapists need greater understanding of how exercise changes pharmacokinetic properties of different classes of drugs. In another review, We show that physical agents being used by therapists have very high potential to influence the absorption and distribution of certain drugs to targeted tissues. Onigbinde et al. 2006. The finger and dosage specification for topical medications. The 21st century healthcare practice can no longer continue with the era of generous, little, or small amount of application of topical medication. The dosage needs to be specific when administered through massage or through the use of electromotive forces. Quantifying appropriate and effective therapeutic dose of relevant medication has been a major challenge in providing qualitative care for clients. There are a few concepts in the condition of topical medication, but prominent among the existing ones are the use of fingertip unit, FTU, and the dosing card. A FTU is defined as the amount of ointment, cream, or other semi-solid dosage form expressed from a tool with a 5 mm diameter nozzle applied from the distal skin crease to the tip of the index finger of an adult, according to Long and Philly, as far back as 1991. FTU is a practical but unquantifiable measure for determining dose of topical medication. One FTU is broadly believed enough to treat an area of the skin. Twice the handprint, where 2 FTU are equivalent to 1 gram. I consider the FTU to be a subjective decision, and it has no metric value or precise measurement. In one of our studies, 67.3 to 85.4% of therapists show poor knowledge of dosage prescription using the fingertip method, Onigbinde et al. 2013. Only 14.6 and 37.2% of therapists knew 1 FTU to be equivalent to 0.5 gram of topical medication. In a more recent study, our research team recorded a disappointing average score of 39% among physiotherapists regarding knowledge of topical medication, and only 13% were using the required fingertip unit to quantify the dose of topical medication. Onigbinde et al. 2024. In order to provide a more measurable metric value for topical application, I led a team of researchers to establish the fingertip unit metric length, FTU-ml. The FTU-ml is a measure of the length of cream or gel from the distal crease to the tip of the index finger of an adult, Onigbinde et al. 2017. Our findings among 600 participants show that the FTU-ml for different age groups range from between 2.4 and 2.7 centimeter length of cream, and there are significant variations across different age groups. This suggested that use of therapy's FTU to quantify the dosage of topical medication for all clients might be inappropriate. We subsequently suggested that the FTU-ml of patients or clients should be used to quantify the required dose, and that 1 FTU over 5 gram is equivalent to a range of 2.4 to 2.7 centimeter length of cream. We also found that the FTU-ml of male was significantly higher than that of the female, Onigbinde et al. 2017. The clinical implication of this study is that the same quantity of drug or FTU cannot be assumed for both genders. Furthermore, we observe significant variations in GAP values across different age groups for different anatomical parts, implying that different parts of the body will require different doses of topical medications. The most important outcome of findings was the predictive equation we developed for FTU-ml in 2017. Despite providing the use of the FTU-ml, I still largely consider the use of meter ruler as a tool to be inappropriate in the clinic. This led to my postulation that clinical syringe tube will be more clinically acceptable to be used in providing dosage specificity for topical medications. I developed the opening of a syringe tube to simulate the conventional 5 mm injection tube. We filled the syringe with methyl salicylate cream and ensured no hair was trapped within it. The modified syringe was used to eject the cream from the 5 mm nozzle of the syringe on the participant's index finger from the distal crease to the tip. The length of the amount of cream expelled from the syringe was then measured and recorded in mils from the calibration. We found an average of 0.67 plus or minus 0.22 mils to be equivalent to 1 FTU. We established that both the FTU-ml and the syringe were reliable and valid as tools to quantify topical medications. Production and patency of standard micrometer ruler and special syringe for quantifying topical emissions are being considered in the future. Clinical practice: the hands, the fingers, and mobilization techniques. Manual therapy can be described as procedure by which the hands directly contact the body to treat body articulations and soft tissues. It is the application of accurate and specific manual force to the body with the sole aim of improving mobility and of preventing disability and pain alleviation. The technique of spinal manual therapy may be classified into direct, indirect, specific, not specific, oscillatory, and manipulative thrust. Mr. Vice Chancellor, sir, nothing interests me as much as my hands and fingers during mobilization techniques. The effect of the fingers during the technique is like magic. There are two effects: the mechanical, distribution of fluid, nutrient, and blood essential for healing to the area being mobilized, and two, the neurophysiological effect. The neurological effect is known as the pain gauge theory, PGT. It was propounded by Merzak and Walker in 1965. The mobilization stimulates the alpha beta large diameter and alpha delta small diameter fibers. Both were myelinated and they travel faster, using velocity of 50 meters per second and 15 meters per second, respectively, ahead of the C fibers, small diameter, which are unmyelinated, and at slow velocity of 1 meter per second, according to Jenkins et al. In 2007. The myelinated fiber block or mask the apothetical gate at the higher center, inhibiting the conduction of pain impulses being carried by the pain fibers, which are the C fibers. Furthermore, virtually almost all diagnostic tests in musculoskeletal dysfunction require the skillful use of the hands and the fingers of the physiotherapist. A physiotherapist can only arrive at a conclusive physical diagnosis if he or she has the skillful hands and fingers. When patients with acute low back pain, especially those with sleep disc or lumbar ankylopathy, are crying and sobbing, I look forward to bring relief to them. I understand their pains to be a case of mechanical derangement, and I'm always confident that hands and fingers alone can bring about the required instant pain relief if the right techniques are employed. Even sometimes, you fix the bone during physical examination with the fingers. It snaps into position, and the pain is almost gone. I have fixed shoulder dislocation in a number of locations while in sport medicine, either during competition or training. I remember vividly how professional players in handball, volleyball, and basketball shouted, "Physio, physio, physio," in pains with the upper limb dangling like a pendulum. It used to be very delightful with all eyes on me at the stadium when success was achieved. It used to be like magic. Very challenging, but doable. I have demonstrated my skill in mobilization techniques, muscle energy and myofascial release technique at several national and international workshops and classes in the last 30 years. Not with anything other than the brain, the hand, and the fingers. I was privileged to facilitate international workshop at the World Congress of Physical Therapy in Lusaka, Zambia in 2004, and Dar es Salaam, Tanzania in 2006 on both back pain and Hungarian technique. I also put my skill forward as Society Cameroonese de Ferroti at Yaoundé in Cameroon in 2019. I went to the international workshop on special invitation and recognition, and I was there with nothing but with my brain, my hand, and the fingers. Teaching-related engagement, academic leadership and distinction, visiting lecturership and external examination. The university stands on a tripod of research, teaching, and services. Along with my extensive and productive research engagement, I have also had rich teaching-related experience within and outside Nigeria, as well as served in various leadership roles within the academic, professional organization, and civil society settings. Among others, I was privileged to serve as a visiting senior lecturer at the Department College of Medicine, University of Malawi, Blantyre, Malawi for 4 years, 2010-2014. I contributed to the creation of the first set of physiotherapies in the history of Malawi. I have served as an external examiner at several universities, including examining undergraduate and postgraduate students in orthopedic and musculoskeletal specialty. I have also had opportunity to present papers in many national and international conferences and workshops, academic leadership and development initiatives. Over the years, I've been privileged to serve in various academic leadership positions in university settings. Among others, I serve as the acting head of department or Department of Medical Rehabilitation at Ayodele University Ilefe between 2018 and 2020. And I served as a BMR coordinator for several years. I couldn't recollect how many years. I am proud to have had the privilege to serve in leadership role in the Faculty of Medical Rehabilitation of University of Medical Science, Ondo City, the first and only Faculty of Medical Rehabilitation to date in Nigeria and West Africa. I serve as the acting dean of the faculty for the 2023-2024 session, following the footsteps of Professor M.O.B. Olagun, acting dean 2022-2023 section. Dr. Michael Egu, now a prof, acting dean 2021-2022. In July this year, 2024, I was privileged to be elected as the first substantive dean of the Faculty of Medical Rehabilitation of this forward-looking university. I am deeply grateful to God and my colleagues for this honor. UNIMED has given me several other opportunities to play leadership roles and drive academic agenda. I was appointed as the chair of the first ever sport council of the university, which effect from 1st August 2024. I have played a pivotal and frontline role in development of the curricula for the postgraduate diploma and MSc program in exercise and sports science and sport medicine. And the first set of the PG students have already completed their studies. More recently, I led development of PhD curriculum in exercise and sport medicine, and students should be admitted into the program in October 2024. The University Doctor of Therapy DPT program of the university took over under my watch as the Dean of the Faculty of Medical Rehabilitation. And the same is true of the Conversion Doctor of Therapy program, the first in the country. Research and travel grants. As an academic physiotherapist, I've been privileged to win several research and travel grants. These include the travel grant to deliver an Hungarian technique workshop at World Congress of Physical Therapy, Dar es Salaam 2006. Research and travel grant from Lato Nigeria Limited to support research work on the effect of high voltage current in osteoarthritis, blood pressure, and fasting plasma glucose. 2010. Travel grants from Nigeria Society of Physiotherapy to attend the World Congress of Physical Therapy, Lusaka in 2004, and Ghana 2010. Research grant from Mocha Nigeria Limited for research work on assessment of quality of sleep of undergraduate students using full and semi-orthopedic beds in 2020. And Teslim grant as a co-investigator for the development, feasibility testing, and implementation of a context and culturally sensitive home exercise mobile application for Nigeria stroke survivors 2023-2024. Professional organization and social activities. Mr. Vice Chancellor, sir, distinguished audience, I have had the privilege to serve my professional organization in different capacities as exemplified by the following positions: National Secretary General 2000-2004, National Vice President 2000-2008 of the Nigeria Society of Physiotherapy, Vice President, World Confederation of Physical Therapists Africa Region 2008-2010, and Chairman of the Nigeria Society of Therapy of Osun State 2010-2014. I was in camp for 8 months in preparation for Olympic Games in Spain in 1992, and I was also among the only 6 physiotherapists who went to the 8 All-African Games at Harare in 1995, where I won a silver medal as an official with a team. I am the Secretary of the Board of Trustees of the Association of Clinical and Academic Physiotherapists of Nigeria, and the Director and Fellow of the Consortium for Advanced Leadership and Mentorship Program, FCMLP. Lest I forget, I am a music producer, a promoter with special interest in upcoming artists. I also shoot and direct films and edit videos in my private studio, Teloshat Studio. Civil society and leadership. I was appointed in 2018 to serve as the Executive Secretary of Odwoti, South Local Government Development Authority, Osun State, by the Executive Governor of Osun State, Ogbeni Rauf Aregbesola, and served in 2020 under Governor Gboyega Oyetola. Awards and distinctions. In my career as both clinical and academic physiotherapist, I've been privileged to be honored with some awards attached too numerous to list, and receive accolades from colleagues and former students attached as Appendix 2. Those who made the pathways. I appreciate the Almighty Allah for creating different pathways through which I met people like Uncle Bimbola Agbebi, who introduced me and asked me, would you study physiotherapy? Ms. Olagunju Balkis ni Agbebi, Mr. Ishola Folorunsho, Dr. Aibu Dairu, Chairman Bauchi State Sport Medicine Association, and personal physician to the governor of Bauchi State between 1991 and 1995. Babayo Sheu, Director General National Sport Commission 1992 to 1995. My godfather, Colonel Dangiwa of Maro, former governor of Kaduna State. Mr. Alfred Rabegunle, Professor Aria Adedoyin, who facilitated my settling down in academics. He made me comfortable. He was my tutor. And Mr. Noel Adege. I would also like to acknowledge the contribution of all my research colleagues, particularly Mrs. Olafinyo, medical laboratory scientist, Duare Togun Gbadebo, a pharmacologist at OAU Ile-Ife, Sylvia Kabala Mentori in Malawi, Tron Westner in Netherlands, Dr. Wolabi and Dr. Bamitale, Pharmacology Department, College of Medicine, OAU, and South Africa, respectively. Dr. Joyce Mutambek, Shamila Nondwe, all in South Africa. Late Dr. Camille Lasisi of Osun State University in Hospital Osogbo. Late Dr. Vivian Kumbuzi, a Zimbabwean, but who practiced in Malawi. They contributed immensely to some of my research work. And I have to acknowledge my teachers, Professor M.O.B. Olaogun, Professor Balogun Joseph, late Professor V.C. Binwuga, Professor Obajuluwa Victor, Dr. Abere Uje, and Professor Talabi, my 2 times postgraduate supervisors. Their collaborative efforts set the pace for my fundamental knowledge. I especially acknowledge the Vice Chancellor of this prestigious university, sir. Professor Adesegun Fatusi, this dream cannot come to reality without him. What a pragmatic and charismatic leader. Who said leaders are not yet born? Mr. Vice Chancellor, sir, you are an epitome of good leadership. Sir, you are destined to lead. Yours won't be like Yoruba adage that says, a valuable tree does not last in the forest. You will live long to an old age to fulfill your good mission on earth. To my family, I am the firstborn and only son of 5 children of late Prince Tijani Adeleke Onigbinde and Mrs. Jarat Mosun Onigbinde, both retired teachers. The Quran mentions the difficulty of childbirth. We have enjoined a man to show kindness to his parents. With much pain, his mother bears him, and with much pain, she brings him into the world. Quran chapter 46, verse 15. Thank you, mommy. She's very, very, very strong now. You did not labor in vain. My sisters are Ayodele, Titilayo, Bola, and Nike. In my nuclear home, I have the rock, Mrs. Mistura Bolaji Onigbinde, who created the foundation. And I have the pillar, the musicians that brought me into music production. Mrs. Aisha Tokishola Onigbinde, who provided the support. My children, Mubarak, a librarian in a federal university. Taiwo, a geographer in the final year. Kende, a barrister. Akimat, a physiotherapist going to 300 level. And I have my Teslimat. My dream is that she should be a physiotherapist, so that we can be 3. And my dream is that my little boy, Zion, should be an audiologist. These are the precious seeds of love from the rock and the pillar. Conclusion. Mr. Vice Chancellor, sir, members of the university management, and their distinguished audience. In human life, there is joy, and then there is pain and hardship, and then there is ease. Among the ease is the use of the hands. The Almighty realized the importance of the hands and the finger when he says, put your hand on the part of your body that hurts you and say, if you are a Muslim, Bismillahirrahmanirrahim. Say your prayer with your hands on that spot, your pains will go. And if you are a Christian, of Christian faith, place your hands on where the pains are, because your hands are actually your power of healing given to you by the Lord. And this is as narrated by Muslim, verse 2202. I have used the natural gift of fingers to fulfill my obligations as a physiotherapist, to alleviate pains associated with body dysfunction. I have contributed immensely to the rare field of pharmacophysiotherapy or rehabilitative pharmacotherapeutics with special focus on transdermal delivery of relevant drugs using procedure of iontophoresis and quantification of specific doses for topical medications, especially in orthopedic rehabilitation. I have saved my clients from the pains of the needle and the side effects associated with prolonged oral drug therapy injection where possible. I have created awareness and contributed to the verdant area of pharmacophysiotherapy as an emerging specialty in physiotherapy to treat pain and avoid disability. Furthermore, I have contributed immensely to improving physical function and promoting quality of life of my clients and imparting knowledge on students so as not to die with my gift of knowledge when I answer the last call in life, the death. Whoever dies with his knowledge without imparting it will not see the good face of God. I don't want to die with this before my death. Mr. Vice Chancellor, sir, this 5th inaugural lecture is unique because the University of Medical Sciences, the first specialized medical institution, is the first and leading citadel of learning in Nigeria, if not in Africa, where a professor of physiotherapy will deliver a lecture that focuses largely on research work that have to do with medications. Pains and disability may be debilitating, but the dexterity of the fingers and injection therapy without the needle are critical to achieve maximum physical function that can guarantee good quality of life for all the clients of physiotherapy. Thank you.
As we come to the end of this inaugural lecture, let me invite the inaugural lecturer, Prof. Ayodele, Teslim, Onigbinde, to just come forward. On behalf of the university community, it is my pleasure to present you this certificate of presentation of inaugural lecture being presented to Ayodele Teslim Onigbinde, Professor of Orthopedic Rehabilitation and Pharmacophysiotherapy, Department of Physiotherapy of our university. Election titled Myriad of Pain and Disability, the Therapeutic Effect of the Fingers and Needle Without Injection, on this day, September 10, 2024.